So I'll be taking us through the Ministry of Health journey to digitizing community health services. And this is how our community health system is organized in the country. As you can see to my far left is a map of Kenya with a population of 50 million people, with 9,500 community health units. And we have 12.2 million households that we strive to reach with community health services. And the way organized is that our community health unit has covers a population of about 5,000 people. And in that unit, we have 10 community health promoters who are supporting 1,000 households, meaning one community health promoter serves on average 100 households. And there's a supervisor who is a community health assistant to every community health unit. And there's a governance structure at that level of community health committee that has a population of, that has a membership of 5 to 7 people drawn from within the local community. So currently we have 107,000 community promoters in the country, and our community health unit coverage is at 96%, because we have 9,100 against target of 9,500. Our community assistants are only 3,250, again in the required number of 9,500, and so we have a coverage of 34% in terms of community health assistants. So community health services are provided within the primary health care context. And so we have a policy landscape, what documents have been developed to guide how we implement primary care and community health services in the country. And so we have a document that is National Health Sector Strategic Plan 2, with the community level included as part of the service delivery system in the country. That was the starting point of community health strategy in Kenya. So we had that included the National Health Sector Strategic Plan 2. Then in 2013, we had a Kenya Medium Term Plan 2 that was running between 2013 and 2017, which also has community health as one of the service delivery points or levels. The same to Kenya Health Policy and Kenya Health Sector Strategic and Investment Plan. That document that included the community health level as one of the 6 levels of healthcare system in Kenya. Then in 2014, we developed the first Kenya Community Health Strategic Framework that ran between 2014 and 2019, which now provided guidance on how we implement community health services in the country. Then in 2020, we had 2 documents. One, Kenya Primary Healthcare Strategic Framework, which again introduces primary healthcare in the country with primary care networks that brings together community health units to form primary care networks. And then in 2020, we had the Kenya Community Health Policy, which now defines how community health system in the country is organized, governance structures, leadership, service providers, and so on. It describes the scope of services for community promoters, as well as community health assistants. It defines how community promoters are identified, recruited, trained, and assigned roles. It also talks about the training in 2 levels, basic training and technical training. Then in 2021, we came up with the Kenya Community Health Strategy again, second strategic framework after the first one expired in 2019. And in this strategic framework 2021, it spelled out the need to digitize community health services. And as a result, we came out with Community Digitization Strategy 2020-2025, which we are currently using, and which defines how we digitize community health services in the country. And this was the document that is guiding how we implement electronic community health system, eCHIS, in the country. So the background to eCHIS is that in our constitution, 2010, the Kenya Constitution 2010, this devolved delivery of health services to county governments, including community health services to county governments. So delivery of health services in the country, in Kenya, it was assigned through this constitution to county governments. But then as that happened, well, before the ministry managed health services countrywide, data collection tools, but as we devolved services to counties, we realized that printing of data tools became a challenge to counties, and we saw community health promoters, by then they were community health volunteers, working without requisite data collection tools and reporting tools. So there was a case where HPs went about doing their household visits, providing services, but didn't have any way to record those services delivered. Further to that, there was no uniformity in the way community health volunteers and now promoters put services, because they each went into households and decided what to do in that household. So there was no uniformity in the way services were provided. And so in 2019, we considered the idea to digitize delivery of community services for efficiency and effectiveness of community strategy in the country. So around that time, we carried out a landscape assessment to help us understand what digital tools exist in the community at that time. And so we found like 28 different digital tools existed at the community level, different parts of the country. All of them run by different partner organizations. So among them, there was one called CHT, which met criteria. So we were doing landscape assessment. We also were subjecting the system that we found to some criteria that would suit our needs for digitization of community services. And so CHT then was picked as the platform of choice for Kenya's eCHIS because it had most the features of what we're looking for, the digital platform for community health in Kenya. So following that landscape assessment and selection of CHT and the platform of choice, we developed and deployed eCHIS version 1 in Kisumu County by the year 2022. We got feedback about the version 1. Then we embarked on the journey to improve version 1 to incorporate some of the suggestions that had been picked from the feedback received in the Kisumu pilot and subsequent deployment. So we then developed eCHIS version 2 based on user feedback and emerging needs. And now we are in 5 counties countrywide that are currently using eCHIS version 2. So what then is eCHIS? We are saying this is a digital solution that supports quality community health service delivery by providing client management decision support, performance management, and automated data management. These are the 3 areas of strength of eCHIS. The area of clients management decision support, performance measurement, you're able to tell who has made their targets, who are likely to buy, and so on. But most importantly, the system enables us to automatically generate or manage our data. And the objectives of eCHIS include provision of standardized quality of community services, so that how a CHP manages a given case in one part of the country, in the same way that same case would be managed by another CHP in another country, because it is all defined in eCHIS. So CHPs don't have that leeway to provide services the way they want. because it's dictated by the system. eCHS also improves capacity of community health workforce to generate and use data. It also improves monitoring and evaluation of key community health performance indicators. So we have identified key performance indicators, we put them into dashboards, and so as you go in, you're able to see where you're doing well and where you need to improve. So some of the features in eCHS, we have more features at community level. That's where there's a lot of work. First and foremost, eCHS has capability to enroll households at the first step towards providing services to those households. Then the other feature is service delivery. And as I said, you've taken into account all services that are defined in the budget policy for CHPs to provide. They have been built into eCHS, and so using eCHS, we're able to do some delivery. We're also able to do client referral, community facility referral. But this is dependent on the readiness of the facilities to receive these referral notifications from the community. For now, we still have got a challenge because the DHP platform that's supposed to be working at the facility is not in many facilities. And so even as much as you have already built client referral module in eCHS, we still cannot do automated referral because the link facilities that are supposed to receive these referrals are not digital yet. So that's a gap. So you're also able to do community-based surveillance. The system is also as a feature of commodity management. So it's able to pick commodities as received, dispensed, balances real time. eCHS also has a feature on messaging for follow-ups, immunization, reminders, and so on. And then finally, there's a feature on data visualization, which is real time with dashboards for informed decision making with targets and indicators. So we have features for subnational level, that is county, sub-county, and facility. So here we have features around support supervision, where the system is able to guide chance on how to supervise the CHPs using eCHS. Then at subnational level, we have a feature on performance management. As I said, then we are able to check and see whether CHPs are meeting their targets or not. Then there's community-based surveillance, data visualization, messaging, and data visualization again. No, data validation rather. Yeah, so chairs are able to go into the system and check on the data that is collected by CHPs and where they feel that they need to make some validations. That then happens. Then at national level, features are fewer. Here we have features around integration in national frameworks, so this is being integrated with other systems. We have features around performance management, community-based surveillance, and data visualization, again with dashboards, including executive dashboards for our senior management. So those are the features we have in eCHS. So this is the path national scale, which we are doing in a phased approach. So phase 1 to national scale ran between June to December 2022. And the areas of focus here were governance framework, developing cost-state implementation roadmap, deployment plan, how will we deploy the system once ready, architecture documentation, infrastructure setup, app hosting, where do you host the app? And then the other area of focus was on MNH workflows, and ultimately coming up with eCHS version 2, which is piloted in a county called Migori successfully. Phase 2 of national scale ran between January to May 2023. And in this phase, we majorly focus on clearing the backlogs, iterative testing and development. This has worked very well. Then a design and development focusing on community management, community-based surveillance, in-app analytics supervision. So the focus on development is in phase 2. Then hosting, zoning review, and service monitoring. So here we were making a decision on how we host the data coming from the system from eCHIS. So ultimately, we decided to have an host instance for every county at the Nine data center. That's how we are now working. Then integrations, specifically integrating eCHIS with AFIA KE, that's the facility-based digital system, which, as I said earlier, it is not widespread. Then integrating also eCHIS with CHIS, which has already happened. Then integrating eCHIS with client registry, which also has happened. And then upgrading CHT to version 4.0. And then the last phase, the third phase, June to December 2023, with the focus on design and development of the remaining project integrations, and then feedback iterations and enhancements, and then analytics. That has already happened. And then we hope to have national scale-up in analytics and integrations happening in 2024, 2025. So let us see where we are as we speak now. So in regard to where we are, we have put a green bullet or blue bullet. Blue meaning it's ongoing, green means complete. So for work stream around architecture, we were supposed to have eCHIS system architecture documentation and infrastructure assessment and data center KPIs. That is done. That was done. As you can see, it's in green. Then for design, phase 2, community-based surveillance, analytics, supervision, and commodity management, all of those are done. They were done by Q1 of 2023. Then the same phase 2 development, we had the commodity management, surveillance, analytics, and supervision. That was done. Then interoperability, eCHIS integration with CHIS, that was done. And AFIA integration, that's ongoing. Same to backlog management iterations, that's ongoing. But for executive and information dashboards, that has been done. And the senior leadership are very happy with these dashboards at the ministry. Then also under development for infrastructure, service monitoring, that's ongoing. Optimal cloud service management, ongoing also. But hosting zoning, as I said, that's already completed. And for deployment, where we want to deploy eCHIS upgrade, all instances on version 2.2, that is done. And scale up, we are still ongoing with scale up. Then tech support and deployment, service desk operationalization, that's ongoing. We already have guidelines for service desk. We already have identified service desk with the requisite infrastructure. Then county-based tech support and level 3 tech support contracts, all those are ongoing. So this is an example of executive dashboard that gives a snapshot of our performance. So as you can see, the first dashboard is in get households registered by county. And in total, we have almost 400,000 households registered. But as you remember from my first slide, we have 12 million households that we all want registered. So this work in progress. But now this gives us a snapshot of how we are doing in regard to household registration. And then in regard to CHPs being enrolled in eCHIS, we have 13,000 CHPs using eCHIS from the dashboard. Against 100,000, 107,000 from the numbers I shared So as you can see, we have a long way to go in getting more CHPs enrolled in using eCHIS, which then will in turn help us register more households in this eCHIS. So the same one, so we're also trying to track household visits. So once household is registered and with CHPs enrolled, then you want to see them visiting households to provide services. And this is just one of the snapshots on the dashboard showing household visits, the household visited on monthly basis. It then would show us which county, which sub-county, as low down up to community activity level, who are doing well in household visit, and those who are so like behind, we can be able to pick that from the dashboard. So we have this dashboard in place. So we have a deployment plan. So what we have done is we have partnered with our partner organizations, and they have shared with the whole country, all the 47 counties. So for those that are in red, that are not assigned to any partner, no partner has taken them up, but the rest of the counties have been taken up, and this partner has doing a commendable job, but they are able to work with the counties with our technical assistance to roll out this in those counties. As you can see, Kakamega County is fully on eCHIS with support of AMREF. So Nairobi is ongoing currently with support of UNICEF and other partners. Migori, Nakuru, Nyeri already covered and with the various partners. So Migori, there's Douala, Nakuru, there's AMREF, Nyeri, there's AMREF. Turkana, there's Chisu, the USAID funded organization. It is scheduled, not yet done. Kilifi is nearly complete with support of AMREF. Tharaka-Nithi, not yet. Vihiga is partial with a path, but Livingwood is also going there to take up the remaining parts of the county. Trans Nzoia, not yet, but they have CHIS to support them. Kericho are at the tail end of their deployment. They are beginning to train their CHPs on Monday next week. Again, support of AMREF. Tana River is in the red of a partner supporting them. So nothing much has happened in Tana River. Siaya is under AMREF and a lot of progress being made. Nandi is AMREF, Kwale AMREF. T2 is complete with CMMB, Catholic Medical Bishops Board. They've done up to CHP training. Kisumu with Living Goods. So Kisumu is not shaded at all because they are on version 1. We are trying to track counties on version 2 the system. And then Kisii is under AMREF, good progress. Kajiado and Nai Africa not yet started. Homa Bay is work in progress with AMREF and LVCT working together. Busia is work in progress under AMREF. Baringo not yet started under Tujenge Jamii. Mombasa is ongoing with LVCT now, ongoing now with LVCT. So next week with LVCT. So I don't know to go through the full list, but the point here is that we have shared up the counties among our partners, and with that approach, we are able to move with speed to support counties to digitize community services. We have a target of doing this by 20th of October. We should have rolled out this eCHIS in all the 43 counties. Because these ones that are not supported, Tana River, Nyandarua, Murang'a, and Nyamira, might not make it by the 20th of October deadline. But the rest of the counties should be using eCHIS by 20th of October. And I think that is the end of my presentation.
I think we've been working very well with this MOH team in getting this delivered, and of course with support from the rest of us. So we very much appreciate Manyugu, the continued support that we are having on this. Obviously, the bigger question that I know the whole team will be having is around how do we also ensure good sustainability going forward? We're in the middle of a very good scaling up, and sometimes it's also good to hear the voice of MOH on matters to do with scaling.
So in regards to our sustainability plan is one, we are working with between national government and county governments to digitize community services in the country, and that is government agenda now, both national government and county government. And so with the involvement of both levels of government, we have national government involved in on provision of devices with eCHIS. We have national government involved in payment of stipends, co-financing this between national and county governments. And so, and we also have, we also put in place a digital health bill, which is united into an act of parliament. And so once all these are fitted into legislative framework, and both of the government are committed to supporting digitization community services, then that, in my view, is a long-term sustainability plan for eCHIS in Kenya, because of the commitment and involvement of both levels of government, and going to the extent of having a legal framework for this process passed by parliament.
Wanyungu, another question is, apart from the DHP challenge, which is the other challenge you have been facing when you are trying to scale up eCHIS?
Yeah, so DHP challenge, I mentioned about that. But basically, for now, the challenge we are facing is that digitization, we didn't know, is very costly. And so even the partners who committed to support different counties, for example, UNICEF committed to support Nairobi. When they came to the ground, they realized that the resources they had could not support Nairobi fully. So they have had to go around again, mobilizing other partners to come in and support. And so we realized that digitization is a very costly venture. So that's one challenge that we are struggling with. But also basically the issue of ensuring that there is sufficient tech support to the eCHIS users and decentralized to count levels. But for now, we are very well supported at national level. Yeah, we have a tech team at national level. We don't have that replicated at count level. So our national team still has to also support the 47 counties. So having strong tech team, at least based in every county, not region, to troubleshoot, to help, to just help with technical support at the central level, that would be great. But also, we're also experiencing a problem with, and this is being worked upon, data submission, because there's a cost to it. Although we are assured that the government will do centralized billing for data bundles, for bundling of data for data transmission, but that hasn't happened. So the burden, I think, still lies again with the service providers, which in my view should not be the case. So that's another area that we are faced with the challenge, but it's being addressed by national government by way of trying to work with Safaricom to do centralized billing, which then will be more efficient in terms of helping us to submit data from CHPs to the national servers. Yeah, I think those are some of the areas that I can point.
There's a question for you, Wanyungu. In our call chat, you can respond to Bengal. All right.
Oh, what is scope of the IPs and government in regard to scale up of the tool, development device and consumables, capacity building? Yes, so the IPs, we've seen the IPs come in specifically for capacity building. So devices, development, consumables, maintenance costs on operational, that has been left to government mainly. And I see IPs only focused on a capacity building. Yeah, so that is how we have shared up roles between government and IPs. Right.
Okay. Thank you.
Hi, everyone. My name is Mercy Amulele. I work with Medic. I'll take you through quickly how community health promoters report on community event-based surveillance. These are the community health promoters get information and from the community, and they are required to report them, especially if there are possible information on public health threat. So once a CHW or a CHP comes across any of them, they are required to report on them. So this is how the, the application looks from their end when they log in. As you can see, this is an example of a CHP area. And down here, you'll see a household, but we only have one. If we had many, they'll be listed there. And when they want to report an event-based surveillance report, they'll go straight to on their profile and click on the floating action tab and pick the community event-based surveillance signal reporting. The CHPs are trained on how to identify the signals and categorize them. So for our case, we will say we have like seven of signals that the CHPs are trained on. So for our case, we'll say we are reporting signal number 2, any death happening in the community. So we'll say that, and then there's a question if the person who died is under your area as a CHP, we say yes. So if we say yes, we are prompted to fill a death report because the CHWs are also required to do death reports in case someone dies in the community. So for our case, we can say yes, or if you say no, there's a place where you can input more details about what happened to, or any relevant information that you think it will be important for maybe your community health assistant or the sub-county team to know. So for our case, you can say the person was in our area and say next, and then we go to the summary page where it has very important information to the CHP to make sure they synchronize their work and have data bundles as they synchronize so that the community health assistant can get this notification and do more follow-up on this because this is a public health threat. And then we submit, and then we can log in as a community health assistant to see how we get that. Because for the community health assistant, they get that as a task. So they go to their task and get the task is there, and then they go to the task and verify by calling the CHP or calling the community or the chief or the church elders, just to get more information on what is happening in the community. And then they get to fill in this form and submit. So yes, does the information match the signal that was listed below? We can say yes, because they have called and confirmed, and the list of signals are listed there for the community health assistant to maybe remind herself on them, or him or herself on it. And then we can say it was true, it was signal number 2. And is this a new signal that hasn't been reported before? We can say no, because it's not a new signal, it's the same as the one that the CHP was reporting on. We say next, and we get to the summary page. And on this summary page, also the chair is advised to synchronize her work, his or her work, so that the next person can see and do more investigation on what is happening in the community. So yeah, and then after the form is submitted, it disappears from the task. So basically that.